Edwards Lifesciences, the company that brought thermodilution to the bedside over 40 years ago, introduces the VolumeView system. This system expands the application of thermodilution technology to enhance patient care through transpulmonary thermodilution. The VolumeView system uses these familiar concepts to measure and derive key elements of oxygen delivery, such as cardiac output and volumetric calculations, to assess components of cardiac output such as preload, afterload, and contractility. In addition, lung water assessments are available that can assist the clinician in understanding lung water's impact on oxygenation. Critically ill patients often deal with imbalances of oxygen delivery and consumption, which leads to organ dysfunction or possibly death. The clinician is faced with the difficult task of using different assessment tools, such as physical assessment, laboratory analysis, non-invasive monitoring, and invasive monitoring to determine if an imbalance exists and how to best treat it. Transpulmonary thermodilution cardiac output uses the same principles as right heart thermodilution, except the thermal bolus is injected into the central venous system and moves across the right heart, lungs, left heart, and out into the arterial tree, where the thermal change is measured over time by an embedded thermistor on a catheter inserted into the femoral artery. By measuring both a change in temperature over time as well as heat loss of the thermal indicator after crossing the lungs, the VolumeView system can assess flow, volume status, ventricular function, and lung water. Transpulmonary thermodilution with the VolumeView system allows for the measurement and derived calculations of the elements that affect oxygen delivery through intermittent transpulmonary thermodilution cardiac output, calibrated continuous cardiac output, intermittent or continuous assessment of systemic vascular resistance, global end diastolic volume, global ejection fraction, as well as cardiac function index. In addition, extravascular lung water as well as pulmonary vascular permeability index can be used, which may affect oxygenation. Cardiac output is an important component of oxygen delivery. If cardiac output is the cause of the imbalance between oxygen delivery and consumption, is it stroke volume or heart rate that needs to be treated? If stroke volume is the cause, then which of these three components of stroke volume, preload, afterload, or contractility need to be treated? Finding the root cause and choosing the correct intervention at the right magnitude is critical in prevention of complications associated with over or under resuscitation of the patient. Transpulmonary thermodilution uses the same modified Stewart-Hamilton equation to measure cardiac output that right heart thermodilution uses, where the patient's blood temperature as well as the injectate temperature is continuously monitored by a computer with each bolus. A computation constant is derived by the computer from an injectate solution of a known temperature, volume, and specific weight. The clinician enters the injectate volume into the computer. Here is how the elements of the Stewart-Hamilton equation relate to the VolumeView system components. After injection, the computer analyzes the area under the curve to calculate cardiac output. The size of the curve is inversely proportional to the cardiac output. The smaller the curve, the higher the cardiac output. A series of boluses are performed and edited to obtain an average value. Once edited, the measured and derived calculations are displayed and timestamped for retrospective review. The transpulmonary thermodilution measurement used to calculate cardiac output can also be used to calculate other physiologic parameters, such as global end diastolic volume, global ejection fraction, and extravascular lung water. These parameters are useful in evaluating and guiding volume resuscitation, ventricular performance, and changes in lung water that develops from disease or interventions. Let's first learn about global end diastolic volume. The formula used to calculate GEDV is intrathoracic thermal volume, or ITTV, scaled to account for the pulmonary thermal volume, or PTV. As previously mentioned, global end diastolic volume is closely related to the volume within all four chambers at the end of diastole. It can be used to assess preload and manage a patient's volume resuscitation. In order to calculate GEDV, we must first calculate intrathoracic thermal volume, or ITTV. ITTV is calculated by identifying the beginning of the injection cycle from a pressure spike measured in the central venous pressure from the VolumeView CVC manifold. The VolumeView system's TPTD algorithm then identifies the peak indicator concentration, followed by its immediate downslope, which is an indication of the mean transit time. Once cardiac output is known and the mean transit time is known, intrathoracic thermal volume can be calculated by multiplying cardiac output times the mean transit time. The downslope time is representative of the flow time through the lungs. Intrathoracic thermal volume is the first calculation of the cardiopulmonary volumes calculated from the TPTD procedure. It represents the total dilution volume within the thorax, which consists of the heart, lungs, and vasculature that is calculated by the VolumeView TPTD algorithm. The GEDV is a reflection of the volume within all four chambers at the end of diastole. GEDV is calculated by scaling ITTV against the slope function, which accounts for the volume contained within the lungs and the pulmonary vasculature. The rate of change of the upslope and downslope of the thermodilution waveform is used to calculate the slope function, which appropriately scales down ITTV to account for pulmonary thermal volume in order to calculate GEDV. GEDV is computed by calculating ITTV and multiplying it against a scale that accounts for PTV. GEDI is indexed against body surface area to give the global end diastolic volume index, or GEDI. The normal range for GEDI is 680 to 800 milliliters per meter squared. When evaluating and treating the balance between oxygen delivery and consumption, GEDI helps manage a patient's preload, whether volume resuscitating or giving your patient a diuretic. A hypovolemic patient may have a GEDI of less than 680 milliliters per meter squared. Notice how the heart enlarges as the GEDI measurement rises. A hypervolemic patient may have a GEDI of more than 800 milliliters per meter squared. Finally, global ejection fraction, or GEF, can be used to assess the patient's ventricular contractility. GEF is calculated by combining the calculation of stroke volume, which is the cardiac output, divided by the pulse rate. Stroke volume is multiplied by 4 to account for the 4 chambers of the heart, then divided by GEDV. Normal range for global ejection fraction is between 25 to 35%. Cardiac function index is a reflection of ventricular performance as an alternative to using global ejection fraction. GEF is useful to determine if ventricular performance is the issue when stroke volume or cardiac output are low. This image demonstrates a low ejection fraction of 24%. The VolumeView system uses transpulmonary thermodilution for the measurement of cardiac output, global end diastolic volume, global ejection fraction, and extravascular lung water to help with the management of some of your most complex patients. In addition to cardiac output, the VolumeView system can calculate the amount of extravascular lung water, or EVLW, which is an assessment of pulmonary edema. This lung water can interfere with the lung's ability to oxygenate blood. Elevated levels of extravascular lung water may be the result of heart failure, volume overload, or lung injury. Extravascular lung water is calculated by subtracting the pulmonary blood volume from the pulmonary thermal volume, leaving the thermal volume within the lungs. EVLW can be used to assess the level of pulmonary edema, which may be the result of heart failure, volume overload, or lung injury, and can interfere with the ability of the lungs to oxygenate the blood. This is indexed against the patient's predicted body weight to obtain extravascular lung water index, or EVLWI. EVLW can be used to assess the level of pulmonary edema and acute lung injury. Pulmonary thermal volume, or PTV, is a reflection of the volume contained within the pulmonary intra- and extravasculature. PTV may also be calculated by multiplying cardiac output by the downslope time, or DST. Pulmonary blood volume is calculated by multiplying GEDV by 0.25, which accounts for the volume of blood contained within the pulmonary vasculature. Extravascular lung water is a useful parameter with diagnostic, prognostic, and therapeutic value in which pulmonary edema or acute lung injury may be assessed. This guidance may be helpful in mitigating the impact on the patient's oxygenation and overall oxygen delivery to the tissues. Pulmonary Vascular Permeability Index, or PVPI, is also another tool that the clinician may use in assessing lung function. PVPI is calculated by dividing extravascular lung water by pulmonary blood volume. PVPI helps the clinician to differentiate which mechanisms are responsible for increased EVLW. PVPI is increased greater than 3 in patients with increased pulmonary permeability edema due to lung injury, and normal in patients with hydrostatic and cardiogenic pulmonary edema. The normal value for EVLWI is reported to be 5 to 7 milliliters per kilogram. Values above 7 milliliters per kilogram indicate pulmonary edema, and values as high as 30 milliliters per kilogram indicate severe pulmonary edema. EVLW is a useful indicator of pulmonary edema and challenges with oxygenation. An EVLWI target under 10 milliliters per kilogram is desired. Edwards Lifesciences EV1000 clinical platform brings it all together with continuous and intermittent information. VolumeView, another view to your patient's status, adding clarity to every moment.